Okay, let's dive in.
Let's do it.
Today, we are tackling something incredibly common, something that touches pretty much everyone at some point, back and neck pain.
Yeah, it's more than just, a personal annoyance for many.
Mm.
The sources make it clear this is a massive global issue.
Absolutely. Looking through the material you shared, the scale is, well, it's pretty staggering.
It really is. We're talking estimated costs exceeding $200 billion annually just in the U.S.
Wow.
And that's factoring in both direct healthcare spending and, lost productivity, lost wages.
And the impact on life is just huge. It's listed as the most common cause of disability for people under 45.
Yeah, and the second most frequent reason people go see a doctor, here in the U.S. anyway.
The sources estimate that over 80% of us will experience significant back pain during our lives.
80%. That's most people.
So our mission today is really to cut through this stack of material, unpack the core insights, and help you understand what the sources highlight about what causes back and neck pain, how it's diagnosed, and crucially, what they say about effective treatment.
Think of this deep dive as your shortcut to getting a really well-informed handle on these incredibly prevalent conditions.
Okay, so let's unpack this right at the beginning. What actually makes up the spine and how does it signal pain?
Well, the sources break down the spine's structure pretty simply. Think of it in like two main parts.
Okay.
There's the front part, what they call the anterior spine. That's primarily the strong, block-like vertebral bodies stacked on top of each other,
Right.
with the intervertebral discs sandwiched in between, and ligaments holding it all together.
And the discs, those are really interesting. The sources describe them as having that jelly-like center, the nucleus pulposus.
Right, surrounded by a tough fibrous ring. That's the annulus fibrosus.
Okay.
These discs are crucial. They make up about a quarter of your spinal length.
A quarter. Wow.
Yeah, and they act like shock absorbers, allow flexibility, movement between the vertebrae.
But the sources point out they change with age, right?
They do. They naturally lose some hydration, some elasticity. That's what they call degeneration. That's a normal process, mostly.
Okay, so that's the front. What about the back?
Then you have the back part, the posterior spine. This is made up of arches, bony projections,
Yeah.
like the spinous processes you can feel running down your back.
Yeah.
These are where muscles and ligaments attach. They provide the anchors that let you bend forward, backward, twist, lean side to side, all that movement.
Now, often the pain that really gets your attention, that comes from the nerves, doesn't it?
Very often, yes. The sources explain how nerve roots branch off the spinal cord and then exit the spine.
And they exit differently depending on where they are. I read that.
Exactly. In the neck, the cervical spine, those nerve roots exit above the vertebral body they're named after.
Okay.
And they have a relatively short path inside the spinal canal before they actually leave.
But it's different lower down.
Yeah, in the lower back, the lumbar spine, it's different because the spinal cord itself actually ends higher up, usually around L1 or L2.
So below that, it's just nerves.
Right. Below that level, you have this bundle of nerve roots called the cauda equina. It's Latin for horse's tail, apparently.
Huh?
These travel down quite a way before they exit the spine. So the lumbar nerve roots travel a much longer distance within the canal before they exit below their corresponding vertebral body.
Which means a problem higher up could affect a nerve lower down.
Precisely. And the sources also note there are naturally tight spots where nerves can get pinched, like areas to the side of the main canal or right where the nerve root actually exits the bone, the foramen.
And in the neck, those little joints can cause narrowing, too, with age.
Yeah, the uncendonie processes, they can contribute.
Okay, so what's a really key takeaway here? Like, what parts actually feel pain?
That's crucial. The sources list things like the outer layer of the bone, the periosteum, the lining around the spinal cord, the dura, the small facet joints in the back of the spine, the outer ring of the disc, the annulus.
But not the jelly center.
Usually not the nucleus pulposus itself, no.
Yeah.
Also, blood vessels, ligaments, those are all pain-sensitive structures.
So the pain usually isn't coming from the core of the disc itself, but from structures around it getting irritated or compressed.
Exactly. That's a subtle but really important distinction the sources make.
And when it comes to understanding your pain, the sources describe different ways it can present.
Right. There's local pain, which is pretty intuitive. You feel it right near the spot that's actually injured.
Yes.
Then there's referred pain. This can be kind of tricky.
Where that?
Because it might not even be coming from your spine. It could originate from internal organs in your abdomen, pelvis, chest.
Really?
Yeah. Usually there are other symptoms related to that organ, but sometimes back pain is all you feel. A clue here is that this kind of pain often isn't affected much by changing your posture.
Interesting. But pain can come from the spine and still be felt elsewhere, right? Like down the leg.
Absolutely. Pain of spine origin can be local, or it can be referred to the buttocks or legs. The sources mention typical patterns,
Right.
like upper lumbar spine problems might cause pain in the groin or the front of the thigh.
Mm.
Lower lumbar issues often send pain to the buttock, back of the thigh, calf, maybe even the foot. And this referred pain can sometimes spread across areas supplied by different nerves.
Okay, and this is different from what people call sciatica, that radicular pain.
Yes, radicular pain is typically sharper, more intense. It travels along the pathway of a specific nerve root, like a line down your leg or arm.
Ah, okay.
The sources highlight it's often made worse by things that increase pressure, coughing, sneezing, straining.
Or stretching the nerve.
Exactly. Or postures that stretch the nerve, like sitting with your leg straight out that stretches the sciatic nerve, L5-S1 roots.
Got it.
Or extending your leg backwards stretches the femoral nerve, L2-L4 roots in the front. If the pain has a burning or electric quality, the sources note that strongly suggests radicular pain.
Burning or electric?
Yeah.
Okay. And there's muscle spasm pain too?
Right. Finally, there's pain associated with muscle spasm, often a more achy, dull pain in the muscles alongside the spine. They feel tense, sometimes makes you hold yourself funny.
And how the pain started is a big clue for doctors too, isn't it? Trauma, gradual onset.
Huge clue. Was it sudden after lifting?
Hmm.
Gradual, after a specific injury. That history is vital.
So with all these different types of pain, potential sources, how do doctors actually figure out what's going on when you walk in?
Well, the sources outline a clinical approach. Starts with a thorough history, then a physical examination.
The whole body?
Yeah, they'll check vital signs, examine other systems, heart, lungs, abdomen to rule out that referred pain from organs. They might feel your abdomen for a pulsating mass, check for tenderness over the kidneys, things like that.
Then they focus on the spine itself.
Yes. They'll look at its natural curves, lordosis in the neck and low back, kyphosis in the mid-back, checking for exaggerations or scoliosis, sideways curves.
What else?
They look for any skin signs along the midline hair tufts, dimples that might hint at something underneath you were born with, or muscle asymmetry from spasm. Pressing right on the bones can sometimes pinpoint an issue there.
Then they'll check how you move, obviously.
Range of motion, definitely. Bending forward is often limited and painful with lumbar spine problems. Bending sideways might worsen pain. Bending backward, hyperextension, can be limited by nerve root issues, facet joints, bone problems.
And distinguishing hip pain is important too.
Crucial. Hip pain can really mimic low back pain. But if the pain is reproduced when the doctor rotates your hip passively, or taps on your heel, that points more towards the hip being the source.
Okay, here's where the sources describe some really clever bedside tests for nerve issues. The straight leg raise test, that's a classic.
It is. The doctor gently lifts your leg straight up, knee extended while you're lying down, stretches the sciatic nerve and L5-S1 roots.
And a positive test isn't just tight hamstrings.
Exactly. A positive test reproduces your usual back or leg pain, not just tightness. Pointing your foot up adds more stretch. They also mention the crossed straight leg raise.
What's that?
Lifting the unaffected leg causes pain in the painful leg. It's less common, but more specific for a disc herniation, the sources say.
And there's a test for different nerves too?
Yes, the reverse straight leg raising test, often done standing. The doctor extends your leg backward, knees straight, stretches L2, L3, L4 roots in the front of the thigh.
And again, positive if it reproduces the usual pain.
Right, usual back or limb pain. For both tests, the nerve issue is usually on a side you feel the pain. Testing the good side first helps.
Beyond these maneuvers, they also do a neurologic exam, right? Checking reflexes and stuff.
That's right, checking for objective signs of nerve damage. Muscle strength, looking for atrophy or muscle wasting. Checking reflexes, knee jerk, ankle jerk. Testing sensation numbness, tingling in a pattern that follows a specific nerve root, a dermatome.
What if someone isn't trying hard with the strength test?
Good question. The sources mention breakaway weakness, where it feels like someone just gives way. Tests like EMG can help sort out true weakness from pain or poor effort. And they include a helpful table showing typical nerve, muscle, reflex, and sensation patterns for different low back nerve roots.
Okay, so you've got the history, the physical exam. What about diagnostic tests? Blood work, imaging, electrical tests. When do those come in?
For simple, acute low back pain less than 3 months, no red flags, the sources say lab tests like blood counts or inflammatory markers are rarely needed.
Red flags being things like fever, weight loss, history of cancer.
Exactly. Things suggesting a serious underlying cause like infection, tumor, or fracture, if those aren't present, labs usually aren't helpful initially.
And imaging x-rays, CT, MRI, when are those needed?
CT scans are great for bone. So acute trauma, looking for fractures, bony fragments, alignment issues, they're quicker than MRI too.
An MRI.
MRI is generally the test of choice for most serious conditions. And for seeing soft tissues, well, the discs, the spinal cord itself, nerve roots, things like an epidural abscess.
What about CT myelography?
That involves injecting contrast dye.
Yeah.
It's particularly good for seeing those tight spots around the nerve roots, bony issues, and it's an option if someone can't have an MRI, maybe they're claustrophobic.
But the sources make a really critical point about imaging, especially doing it early on.
This is a huge takeaway.
Yeah.
They highlight that even though imaging use has skyrocketed, it hasn't necessarily led to better outcomes for back pain overall.
And the kicker.
The kicker is degenerative findings, disc bulges, disc degeneration, facet joint arthritis are incredibly common in people who have absolutely no back pain, perfectly normal, asymptomatic people.
So just because an MRI shows degenerative disc disease doesn't automatically mean that's the cause of the pain you're feeling right now.
Exactly. That finding might just be a normal sign of aging that happens to be there. The sources warn that early imaging can lead to this cascade effect. More tests, more treatments, maybe unnecessary anxiety and costs.
So guidelines recommend against routine imaging early on for non-specific pain.
Right. Guidelines, like those mentioned from the American College of Physicians, strongly recommend against advanced imaging like MRI within the first 6 weeks for typical acute low back pain, unless there are those red flags we talked about.
Okay. What about those electrical tests, EMG, and nerve conduction studies? What do they show?
These tests look at how the peripheral nerves and muscles are actually functioning electrically. Nerve conduction studies measure signal speed along nerves.
An EMG.
EMG, electromyography, looks at electrical activity in the muscles. It can detect patterns that indicate damage to the motor part of a nerve root re-innervation. It provides objective evidence of nerve injury.
So it can be helpful if the exam is tricky because of pain.
Exactly, or if weakness seems inconsistent. It helps confirm if there's actual nerve damage.
But they aren't useful for all types of back pain.
Correct. EMG and nerve conduction studies will be normal if the pain is just from nerve irritation without actual axon damage, or if only sensory nerve fibers are affected in a way the test doesn't pick up. And they aren't helpful for pain that's only in the midline of the back without radiating.
So putting it all together, history, exam, maybe some tests.
Well,
How does a doctor feel confident about a diagnosis? It sounds complex.
it is. The sources emphasize that a diagnosis is most solid when all the pieces fit together consistently. Your symptoms, the physical exam findings, and any relevant test results like imaging or EMG.
But remembering that imaging findings alone aren't the whole story.
Absolutely. They reiterate the common findings like disc bulges or facet arthritis, seen so often in people without pain, shouldn't alone dictate treatment. Your actual symptoms, how they affect your function, those are key.
That makes a lot of sense. Okay, let's delve into some of the specific causes of back and neck pain that the sources detail. Lumbar disc disease seems like a really big one.
It is very common, yeah, particularly at the L4, L5, and L5S1 levels in the lower back. Being overweight increases the risk. It's unusual before age 20, and actually rare in the elderly because the disc composition changes.
And symptoms can vary a lot.
Hugely. It can be asymptomatic, cause back pain only or referred pain, or that sharp radicular pain down the leg.
And this is where the disc's jelly center, the nucleus, can push out.
Yes. The nucleus pulmonis can bulge or herniate through that outer ring, the annulus fibrosus. This can press on the outer ring itself, which is pain sensitive,
Okay.
or directly on the nearby nerve root. But the sources also stress that inflammation around the herniated disc plays a really significant role in causing pain. It's not just mechanical pressure.
So it's chemical irritation too.
Seems like it.
Mm-hmm.
Symptoms can include limited motion, especially bending forward, and those specific patterns of weakness, numbness, reflex changes depending on which nerve root is involved. Though remember, that table they included shows there can be variations.
And the imaging correlation is tricky, like you said earlier. Still applies here.
It still applies. MRI or CT myelogram can show the herniation clearly. But the sources note again, up to a third of adults without back pain might have a disc protrusion on imaging.
Wow.
So seeing a bulge doesn't automatically confirm it's the cause of someone's pain. The diagnosis is strongest when imaging findings match the symptoms and exam.
Is there any good news about herniated discs?
Yes. The good news is they often shrink or spontaneously regress, resolve on their own over time. quite often, actually.
That's encouraging. Now, the sources also highlight a really serious condition called cauda equina syndrome.
Yes, this is a true medical emergency. It involves severe compression of that whole bundle of nerve roots, the horse's tail, below the spinal cord.
What are the signs?
Severe low back pain, weakness or loss of reflexes in both legs, numbness in the groin or saddle area,
Saddle area.
like where you'd sit on a saddle,
Yeah.
and critically, loss of bladder or bowel control.
Okay, that sounds urgent.
It is. It's often caused by a large ruptured disc and usually requires urgent surgery to decompress those nerves. Time is critical.
Okay. Moving on from acute disc issues, what about degenerative conditions? Just sort of wear and tear stuff.
Lumbar spinal stenosis is a common one, especially as people age. This just means the spinal canal in the lower back has narrowed.
And the classic symptom is?
Myogenic claudication. That's pain in the back, buttocks, or legs that starts when you walk or stand for a while.
I think it's better when you sit.
Exactly. Relieved by sitting down.
Yep.
Unlike vascular claudication, where walking brings it on but standing is okay, with neurogenic claudication, just standing still can provoke the pain.
And this is where leaning forward helps, like the shopping cart sign.
Yes. Leaning forward, like over a shopping cart or sitting, maybe riding a stationary bike, often provides relief because those positions slightly increase the space in the spinal canal.
Is it common?
LSS is very common, yeah, seen in maybe 6–7% of adults. But again, many people with mild to moderate narrowing on imaging have no symptoms at all. MRI is usually the best imaging test to see the anatomy.
And treatment for stenosis, what do the sources say?
Well, conservative approaches are often tried first. Things like NSAIDs for pain, exercise therapy.
Okay.
If the neurogenic claudication is really disabling and not improving with medical treatment, or if there are clear progressive neurological signs, then surgery to decompress the spinal canal, a laminectomy, is an option.
Does surgery help?
Surgery tends to provide faster symptom relief and improved function compared to non-operative care, yeah. Though the sources do note symptoms can sometimes recur years later, maybe 7 to 10 years down the line.
What about narrowing just where the nerve exits the spine, not the central canal?
Good point. That's called neural foraminal narrowing or lateral recess stenosis. It's often due to osteoarthritis as well. Bony spurs, osteophytes, or enlarged facet joints crowding the space where the nerve root leaves.
Can that feel like a disc herniation?
Absolutely.
Yeah.
It can cause symptoms indistinguishable from a disc herniation, usually unilateral radicular pain down one leg, but the treatment might differ depending on the cause.
So imaging is key there.
Imaging, like CT or MRI, is needed to pinpoint the anatomical cause. Is it bone spurs? Is it the facet joint? That helps guide treatment. Sometimes surgery, just to open up that specific hole, the foramen, is needed.
The sources mentioned facet injections, but weren't very enthusiastic.
Right. They note that injections into the facet joints are sometimes used, maybe diagnostically or therapeutically, but they lack strong clinical data supporting their effectiveness as a long-term treatment for stenosis or facet pain.
And the general term for osteoarthritis of the spine is spondylosis.
Correct. Spondylosis. It's common later in life, especially in the neck and lower back. Causes pain that's typically worse with movement, stiffness, often feels better with rest.
And again, imaging doesn't always match the symptoms.
Exactly the same story. You can have significant pain with minimal findings on X-ray or MRI, or you can have impressive-looking degeneration and feel perfectly fine.
Okay. What about spondylolisthesis? That sounds complicated.
It just means one vertebral body has slipped forward on the one below it.
Slips forward.
It can be associated with a stress fracture in a part of the vertebra called the pars interarticularis, that's spondylolysis leading to listhesis, or just from severe degeneration of the joints or sometimes trauma.
Does it always cause pain?
No, it might be asymptomatic, or it can cause low back pain or compressed nerve roots. The L5 root is commonly affected or contribute to spinal stenosis. Rarely, it can cause cauda equina syndrome.
Can doctors feel it?
Sometimes, yeah. They might feel a step off when pressing along the spine. X-rays taken while bending forward and backward can show if the slip is unstable and moving.
When is surgery considered?
Usually for significant instability like 5–8 millimeters of movement on those bending X-rays, or if there's a progressive neurological deficit, or pain that just isn't responding to conservative measures like physical therapy.
Okay, the sources also cover more serious potential causes like neoplasms, tumors.
Right, and unfortunately back pain is the most common neurological symptom for people with cancer.
Wow, most common.
Yeah, and it's the very first symptom in about 20% of cases. It's usually due to cancer that has spread, metastasized, to the vertebral bones, most often in the thoracic spine.
How is cancer pain different from typical mechanical back pain?
A key difference the sources highlight. Cancer pain is often constant, dull, it's unrelieved by rest, and can often be worse at night.
So pain that wakes you up or doesn't get better lying down, that's definitely a red flag.
Absolutely. Needs investigation. Early diagnosis is crucial for outcomes. MRI, CT, or CT myelography are used for imaging, whichever can be done fastest.
And if they find one spot.
Imaging the entire spine is important because the sources say about a third of patients with one vertebral metastasis have others elsewhere.
Okay. What about infections? Can they cause back pain?
Yes, definitely. Like vertebral osteomyelitis, which is a bone infection. Often bacterial, staph is common. Or TB can affect the spine POTS disease.
Where does the infection come from?
Can spread from the skin, urinary tract, sometimes related to IV drug use or procedures.
And the symptoms?
The classic presentation is back pain at rest and tenderness right over the infected vertebra. Inflammatory markers in the blood, like ESR or CRP, are usually elevated. Fever and high white blood cell count are less common than you might think. MRI is very sensitive for picking this up. Infections can also affect the disc itself, discitis, or form an abscess.
A spinal epidural abscess sounds pretty serious.
It is. It's a collection of pus in the space around the spinal cord, pressing on things.
What are the signs of that?
Typically presents with back pain, often worse with movement or touch, fever, maybe radiating pain down a leg, or signs of spinal cord compression like leg weakness or numbness. If someone develops a couple of these signs over a few days or weeks, it's highly suspicious. Requires an urgent MRI.
Okay. The sources also mentioned something called lumbar adhesive arachnoiditis. What's that?
This is a less common but really difficult condition. It involves inflammation and scarring in the space around the spinal cord and nerve roots, causing them to kind of clump together.
And that causes
Chronic back and leg pain, often with progressive neurological problems affecting multiple nerve roots. It's tough.
what causes it?
Interestingly, the sources note a geographical difference. In the U.S., it's most frequently seen after multiple lumbar surgeries. But globally, in developing countries, chronic infections like TB are still a more common cause.
Can imaging show it?
Yes, imaging can show characteristic findings like clumped nerve roots. But unfortunately, treatments are often unsatisfactory. It's a really challenging problem.
Okay. Trauma is obviously a clear cause of pain, fractures, dislocations.
Right. These are painful and carry the risk of spinal cord injury if they're higher up, above L1 or so. Immobilization is crucial.
Can fractures happen without major trauma?
Yes, especially in people with weakened bones, osteoporosis, long-term steroid use, underlying infection, or tumor. Those are called pathologic fractures.
What about typical traumatic fractures?
Often from falls, car accidents, direct blows. It can be compression fractures where the front of the vertebra wedges down, or burst fractures where it shatters more significantly. Neurological impairment is common, and early surgery might be needed. CT is typically used after significant trauma.
What about minor trauma, like a fall or whiplash? Do you always need x-rays?
For minor neck trauma, there are specific low-risk criteria like the NXUS criteria or Canadian C-spine rules that can help doctors safely avoid unnecessary x-rays. But the sources caution these need to be applied carefully, especially in elderly patients or those known to have osteoporosis who might fracture more easily.
And terms like sprain or strain, what do those mean in the context of back pain?
The sources describe these as minor self-limited injuries, often from things like lifting something awkwardly, a simple fall. They note the terms are used pretty loosely and don't really pinpoint a specific anatomical problem. The pain is usually just limited to the lower back, doesn't radiate much.
Whiplash from car accidents is common too.
Very common. A rapid neck flexion extension injury. The sources suggest the small facet joints in the back of the neck are likely involved. It's important not to call something whiplash if there's actually a fracture, disc herniation, head injury, or clear neurological signs.
Does it usually get better?
Often it does,
Mm-hmm.
but the sources note up to 50% of people can still have persistent pain a year later. Interestingly, they mention a study from Australia suggesting that removing personal injury compensation was associated with improved recovery rates at 1 year. Makes you think.
Yeah. Does imaging help with whiplash?
Not usually right away, the sources say. It's not cost-effective acutely.
Yeah.
But if symptoms are still significant after 6 weeks or so, then imaging might be helpful to look for other causes.
Okay, let's talk about some less common but important causes. Metabolic conditions that affect bone.
Osteoporosis is the big one here.
Yeah.
Weakens the bonds, making the vertebral bodies prone to compression fractures.
Even without a fall.
Often just from simple daily activities, especially in older women post-menopause or people on long-term steroids. And here's a surprising stat from the sources. Up to 2/3 of compression fractures seen on imaging are actually asymptomatic.
2/3. Wow, so people are walking around with fractured vertebrae and don't know it.
Apparently so, but they can cause significant pain when they do occur. And having one compression fracture significantly increases your risk of having another one, about 20% risk in the next year.
When should a doctor suspect something other than simple osteoporosis?
If the fracture is higher up, above the mid-back, T4, or if the person is young, has a fever, unexpected weight loss, or a known condition predisposing to other causes.
What does the pain from a compression fracture feel like?
Usually localized pain right over the fracture site, sometimes radiating in a nerve root pattern. It's typically made worse by movement, and pressing right over the affected bone often reproduces the pain.
And treatment?
Managing the pain is key. Initially, acetaminophen and SAIDs, maybe a short course of opioids for severe pain, sometimes bracing. But crucially, treating the underlying osteoporosis is essential for prevention. The sources point out this is often inadequately done.
What about those procedures where they inject cement? Vertebroplasty.
Vertebroplasty, or kyphoplasty. They're sometimes used for severe debilitating pain from acute fractures. But the sources note they remain somewhat controversial regarding their overall benefit compared to conservative management.
Paget's disease was another metabolic cause mentioned.
Yeah, Paget's disease of bone causes abnormal bone remodeling. Bones become thickened, dense. You can see it on X-ray. It can be a source of back pain and can even compress nerves, but it's often a diagnosis considered after ruling out more common causes.
Autoimmune inflammatory conditions, like arthritis.
Yes, things like rheumatoid arthritis, ankylosing spondylitis, or the arthritis linked to psoriasis or inflammatory bowel disease, like Crohn's or ulcerative colitis. These can cause back and neck pain, often starting insidiously, maybe with significant morning stiffness.
And some causes are present from birth or develop early on, congenital stuff.
Right, like spondylosis, that defect in the pars interarticularis part of the vertebra. It's common in adolescence, often related to repetitive stress from sports. It's the most common cause of persistent low back pain in teenagers, actually. CT is best to see it.
Scoliosis.
Abnormal curvature of the spine. Can be congenital, develop during growth, or even develop in adulthood due to degeneration, degenerative scoliosis. Can sometimes progress and cause problems with walking or even breathing if severe.
Spina bifida occulta.
That's a failure of the back part of the vertebra to close fully, usually harmless, an incidental finding on X-ray, sometimes associated with skin signs over the area, like a dimple or patch of hair. The spinal cord itself is normal.
Tethered cord syndrome sounds more serious.
It can be. The spinal cord is anchored lower down than normal, often presents in childhood or young adulthood with progressive symptoms like leg weakness, bladder problems, sometimes pain in the perineal area. MRI shows the low-lying cord, but it can sometimes be an incidental finding too.
Okay, going back to referred pain for a second, pain not from the spine. What specific examples from the sources should we be aware of?
Right, pain from organs can be felt in the spine segment that shares the same nerve supply. So upper abdominal issues, think stomach ulcers, pancreas problems, kidney infections, can cause pain in the lower mid-back or upper low back, thoracolumbar region.
Lower abdomen.
Lower abdominal issues often refer to the mid-lumbar spine. Pelvic problems, gynecologic issues, bladder problems often refer to the sacral or tailbone area.
Any key differences from spine pain?
Again, local spine signs like tenderness when pressing on the bones or muscle spasm are often absent, and the pain isn't usually changed much by routine spine movements.
The sources specifically call out abdominal aortic aneurysm, AAA.
Yes, critically important not to miss. A leaking or contained rupture can cause sudden severe low back pain. While the classic textbook picture is abdominal pain, shock, and back pain, the triad is only present in less than 20% of cases, the sources say.
So it can be subtle.
It can present non-specifically. It can be mistaken for kidney stones or just bad back pain. A careful abdominal exam looking for a pulsatile mass is important, but imaging like ultrasound or CT is needed urgently if there's suspicion.
And gynecologic or urologic causes?
Uterine issues, like endometriosis or even just the uterus tilting backward, can cause pain in the low back or sacral area, sometimes worse before periods or with prolonged standing. Pregnancy itself commonly causes low back pain radiating to the thighs in the later stages.
Prostate cancer.
Can spread to the spine and cause significant back pain. Kidney stones are notorious for causing severe flank pain that often wraps around to the back, usually unilateral.
So a key clue for referred pain might be constant pain, not changing with position.
Often, yes. And the sources emphasize again, constant worsening pain that isn't relieved by rest, especially at night, should raise suspicion for a more serious cause, perhaps nerve infiltration by a tumor.
Finally, the sources mention some less specific or harder to categorize causes, like postural pain.
Yeah, postural back pain is a term often used for chronic low back pain, where no specific physical lesion is found on imaging or exam. Exercise is generally helpful here.
And psychological factors.
The sources do touch on how chronic back pain can sometimes be associated with psychological factors, compensation issues, substance abuse, or other chronic pain syndromes. Conditions like depression or anxiety, or a history of childhood trauma, are noted as factors sometimes associated with chronic low back pain. Preoperative psychological assessment is sometimes used.
And sometimes the cause just isn't clear.
Occasionally, yeah. Especially after multiple surgeries where maybe the initial reason for surgery wasn't crystal clear. The sources mention scoring systems exist to try and predict surgical success in these complex cases.
Wow. It sounds like the potential list of causes is incredibly long and varied. Really highlights why figuring out the exact source isn't always straightforward.
It really does underscore the complexity.
And to bring this into a global perspective for a moment.
Yeah. The sources cite data from the Global Burden of Disease study.
Yeah.
Low back pain was the #1 cause of years lived with disability worldwide in 2019.
Number one globally.
And neck pain was #2. And those numbers are climbing, especially with aging populations. It demonstrates the massive burden these conditions place everywhere.
That context is just powerful. Okay, so we've covered a lot. The anatomy, how pain presents, diagnosis, this huge list of causes. Let's pivot to treatment. Based on these sources, what actually works for back and neck pain?
Right. The sources generally distinguish between managing acute pain, usually defined as less than 12 weeks, and chronic pain lasting longer than 12 weeks. And also whether or not there's radiating nerve pain, radiculopathy involved.
Okay, let's start with the most common scenario. Acute low back pain without radiculopathy. That typical sudden onset backache, no leg pain.
Right, and the prognosis here is actually excellent for most people. The sources state that over 85% recover well.
That's really high.
It is, although recurrence is common. About 2/3 might have another episode within a year. But the key is, a lot of people improve spontaneously, on their own, which is really important to remember when we evaluate whether a specific treatment works.
So what's the first step?
Initial focus, as we discussed, is ruling out those red flags for serious issues. If there are no red flags, the sources are clear. Imaging and lab tests are generally not necessary.
Okay, so what should someone do when this happens? Just rest in bed?
No, this is a key insight, a major shift from older advice. The sources strongly recommend avoiding prolonged bed rest.
Avoid it.
Yes. They state it shouldn't be used or should be limited to a maximum of 1 or 2 days if absolutely necessary. Studies clearly show it doesn't speed recovery and might even hinder it.
So what's the recommendation instead?
Resume normal daily activities as soon as possible, as tolerated. Just avoid really strenuous manual labor initially.
Why is staying active better?
The sources highlight the benefits. It's better for your cardiovascular health, maintains bone density and muscle strength, potentially helps with endorphins and pain perception. Specific back exercises, though, are not shown to be beneficial for acute pain, just normal activity.
Okay, what about medications for acute pain?
First-line options are NSAIDs, like ibuprofen or naproxen, and acetaminophen, Tylenol.
Is one better than the other?
The sources say there's no clear evidence that NSAIDs are superior to acetaminophen for acute low back pain. But they do remind us that NSAIDs carry risks, kidney issues, stomach bleeding, especially for people with other health conditions or older adults. Acetaminophen is generally safer if it works for the pain.
What about muscle relaxants?
Muscle relaxants like cyclobenzaprine or methocarbamol could be helpful for muscle spasm, according to the sources. But they often cause sedation, drowsiness. So taking them only at nighttime might be a better strategy for some people.
And opioids, like codeine, hydrocodone?
Big caution here from the sources. Opioids and tramadol are explicitly not first-line options for acute low back pain.
Not first line.
Definitely not. They should only be considered for severe refractory pain that isn't responding to NSAIDs or to acetaminophen. And critically, the duration should be strictly limited, ideally just 3 to 7 days.
Why the strong caution?
The sources strongly emphasize the growing evidence of serious risks associated with opioids. Even short-term use has risks like nausea, constipation, sedation. And the long-term risks, dependency, addiction, overdose, falls, hormonal issues, are significant. There's a major push to reduce opioid use for back pain because of these harms.
Okay, so stick to NSAIDs or acetaminophen first, maybe a muscle relaxant. What treatments do the sources say are not supported by evidence for simple, acute low back pain?
There's a pretty long list of things that lack good evidence or are explicitly not recommended in guidelines discussed in the sources. This includes oral steroids like a Medrol dose pack, steroid injections, anti-seizure medications like gabapentin or pregabalin, antidepressants for acute pain, most OBL therapies, spinal manipulation for acute pain, evidence is weak, physical therapy, again for acute simple pain, early PT not shown better than advice to stay active, massage for acute, acupuncture for acute, laser therapy, therapeutic ultrasound, back braces or corsets, 10 ENS units, special mattresses, lumbar traction.
Wow, that's a lot of commonly used things. What about heat or ice?
Many people find temporary relief with topical heat or ice packs, and they're low risk. But the sources note there's actually unproven overall benefit for acute low back pain in rigorous studies. Still, probably fine to use if it feels good.
So a big part of managing acute back pain sounds like simply educating patients and reassuring them.
Exactly. The sources stress the importance of reassuring people about the generally excellent prognosis, the high likelihood of spontaneous improvement, educating them on which treatments are actually evidence-based, guiding them on activity modification, stay active, and explaining the risks of unnecessary tests and overtreatment. Patient participation in choosing therapy helps too.
Okay, that covers acute pain well. Now, let's shift to chronic low back pain without radiculopathy pain lasting over 12 weeks. No nerve root symptoms down the leg.
Right, and this group accounts for a huge portion, maybe 50%, of the healthcare costs associated with back pain.
Are there factors that make someone more likely to develop chronic pain?
Yes, the sources list several risk factors. Things like obesity, being female, older age, having had previous episodes, having pain that limits mobility early on, presence of leg pain even without clear radiculopathy, psychological distress like depression or anxiety, poor general health, physical inactivity, smoking, job dissatisfaction, or having widespread pain elsewhere in the body.
For chronic pain, does the treatment goal change?
It often shifts slightly, yes. While pain relief is still important, the primary goal for chronic pain management is often improving function and activity tolerance, helping people do more despite the pain. Pain relief might be a secondary, though still important, goal.
And the sources express concern about overtreatment here too, maybe even more so.
Absolutely. They are very clear about interventions that guidelines explicitly recommend against for chronic low back pain without radiculopathy because of lack of evidence or potential harm.
Such as?
This includes SSRI antidepressants like Prozac or Zoloft, generally not helpful for pain alone. Any type of injection, epidural steroids, facet joint injections, trigger point injections.
No injections for chronic pain without sciatica.
Generally not recommended based on the evidence cited. Also on the do not recommend list, 10 NS units, lumbar supports or braces, traction, radiofrequency ablation, burning the nerves of the facet joints, and procedures done inside the disc itself. Intradiscal therapy.
So what is recommended? What has the best evidence according to these sources?
Exercise therapy is considered a mainstay and is strongly recommended.
What kind of exercise?
Various types seem helpful. Core strengthening, stretching, general aerobic activity like walking or swimming. Supervised programs often work better initially. Intensive exercise programs seem beneficial. It's really about finding something you can stick with.
What else?
Treating co-occurring depression is important, as it often goes hand in hand with chronic pain. Intensive multidisciplinary rehabilitation programs.
What are those?
These combine physical therapy, exercise, psychological approaches like CBT, sometimes vocational counseling, or workplace evaluation. The sources suggest that these appear to offer some benefit for people who haven't responded to simpler approaches, but they caution the evidence is somewhat limited, and these programs are intensive and costly.
Medications for chronic pain. Are they different?
Short courses of NSAIDs or acetaminophen can still be used for flare-ups. An antidepressant called duloxetine, Cymbalta, is approved for chronic low back pain and can help with both pain and depression. Other older antidepressants, tricyclics, might also offer modest pain relief, especially if depression is present.
Opioids for chronic pain.
The benefit of long-term opioids or muscle relaxants for chronic low back pain is much less clear, and the risks are significant, generally discouraged as a primary strategy.
You mentioned cognitive behavioral therapy, CBT. What exactly is that?
CBT is a type of psychological therapy. It focuses on how psychological factors, thoughts, feelings, beliefs, and social factors influence the experience of chronic pain. It helps patients learn skills to modify their thinking patterns and behaviors related to their condition, cope better, and become more active.
Does it work?
Studies cited in the sources show CBT can reduce both disability and pain levels in people with chronic low back pain. The benefits seem to be similar in magnitude to those seen with exercise therapy, so it's a recommended approach.
What about complementary approaches like chiropractors or acupuncture for chronic pain?
The sources suggest that spinal manipulation, like chiropractic and massage, may offer some short-term pain relief for chronic low back pain, but there's no strong evidence for long-term benefit. And they note manipulation carries potential risks, especially in the neck.
Acupuncture.
Acupuncture trials are interesting. They often show that true acupuncture isn't significantly better than sham acupuncture, using needles superficially or in the wrong places. However, both true and sham acupuncture often perform better than usual care or no treatment.
So maybe a placebo effect.
That's what the sources suggest is likely playing a strong role. But if it provides relief, some might argue the mechanism isn't the most important thing. Still, guidelines often don't strongly recommend it based on the lack of specific effect beyond placebo.
Okay, just to reiterate on injections or other procedures for chronic pain without nerve symptoms.
The sources are quite definitive here. For chronic low back pain without radiculopathy, there is no clear evidence that injections like epidural steroids or facet joint injections are sustainably effective.
Even if used diagnostically. Like, inject the facet joint, pain gets better, doesn't that prove it's the source?
It seems logical, but the sources point out it's hard to interpret. Temporary relief could be placebo, or maybe the injected medication gets absorbed systemically and has a general effect, or maybe it helps inflammation distal to the joint. It's not considered a reliable diagnostic tool in isolation.
And intradiscal treatments or radiofrequency?
Intradiscal therapy, like heating the disc, and radiofrequency procedures targeting facet nerves or the disc itself, are generally not supported by current evidence or recommended in guidelines for chronic low back pain without clear nerve compression, according to these sources.
Okay. What about surgery? Specifically spinal fusion for chronic back pain without radiculopathy or instability.
The sources describe the case for fusion surgery in this situation as weak. Yes, some studies show modest benefit compared to doing nothing, but other high-quality studies show no significant benefit compared to intensive, structured, non-surgical treatment programs, combining physical and psychological therapy.
But surgery adds risks and costs?
Exactly. Surgery significantly increases costs, hospital stays, and potential complications, often without providing better long-term outcomes than comprehensive medical management for this group of patients.
So when might fusion be considered?
Guidelines suggest fusion might be a consideration only for severe, disabling chronic low back pain that has not responded to an adequate trial of optimal non-surgical treatment, which should include both physical and psychological approaches. But given the high cost, high variation in practice, and increasing rates without clear superiority, it's under intense scrutiny. Insurance coverage is often limited for these controversial indications.
What about artificial disc replacement?
Lumbar disc replacement for single-level disease, L3-S1, is approved as being not inferior to fusion in some studies, but the sources note it remains controversial. Long-term failure rates are unknown, and it might have more complications in some cases.
So the big picture for chronic back pain without radiating symptoms based on these sources. The evidence heavily favors non-invasive approaches like exercise, CBT, and managing expectations over many common interventions like injections or fusion surgery.
That is precisely the picture these sources paint. Active self-management strategies are key.
Okay, now let's move to the scenario of low back pain with radiculopathy sciatica, pain shooting down the leg.
Right, pain following a specific nerve root pattern.
How's the prognosis here? Is it different?
It's also generally favorable, maybe takes a bit longer. The sources note that substantial improvement is expected over weeks to months for most people. And remember that stat. The herniated disc itself often shrinks or resolves spontaneously in about 2/3 of people within 6 months.
So the body often heals itself.
Quite often, yes. So the goal of treatment is primarily symptomatic relief while that natural healing process occurs.
Activity level recommendations, still stay active.
Yes. Similar to acute pain, the sources recommend resuming normal activities as tolerated. Bed rest is also shown to be ineffective for sciatica.
Medications, anything different?
NSAIDs and acetaminophen are still the mainstays for pain relief.
Yeah.
Short courses of opioids, again, strictly limited duration, 3 to 7 days perhaps, can be considered for severe, acute radicular pain to get over the worst hump.
What about injections or steroids for sciatica? Do they work better here?
Epidural steroid injections can provide temporary symptom relief for acute disc-related radiculopathy. They might help calm down the inflammation around the nerve root.
But do they fix the problem or prevent surgery?
The sources emphasize that while they can help with pain temporarily, epidural steroids do not appear to change the underlying natural history or reduce the likelihood of needing surgery later on.
What about oral steroids, like a Medrol pack?
A brief course of high-dose oral steroids might be helpful for some patients with acute disc radiculopathy, according to the sources. However, they note that specific regimens haven't been rigorously studied, and the benefit is likely modest and temporary if present. Risks of steroids need consideration too.
Okay. When is surgery definitely the way to go for radiculopathy?
There are clear indications for urgent surgery. That includes cauda equina syndrome, which we discussed bowel bladder dysfunction, saddle anesthesia, or signs of progressive spinal cord compression.
What about progressive weakness?
Yes, progressive motor weakness due to nerve root injury, confirmed by clinical exam and perhaps EMG, is also generally considered an indication for surgery to prevent permanent nerve damage.
What about surgery just for the pain if it's really bad but not getting worse neurologically?
Elective surgery is an important option for disabling radicular pain that significantly impacts function and quality of life that has failed to improve despite an adequate trial of optimal conservative treatment.
How long should conservative treatment be tried first?
Generally, a minimum of 6 to 8 weeks, according to the sources.
So surgery isn't a first resort for pain alone, but it's a valid option if significant pain persists despite trying other things for a decent amount of time.
Exactly. And randomized trials comparing surgery, usually discectomy, to conservative management for sciatica show a consistent pattern.
Which is?
Surgery typically provides faster pain relief and functional improvement in the short term, the first few months. However, the outcomes are often similar between surgical and non-surgical groups in the longer term, like after 1 or 2 years.
So both are reasonable options.
Yes. The sources conclude both are reasonable approaches. The decision often comes down to patient preference, the severity of symptoms, and individual needs. For example, does someone need rapid pain relief to get back to a physically demanding job? Or are they comfortable waiting longer for likely, albeit slower, improvement with continued conservative treatment?
What does the surgery typically involve for a herniated disc causing sciatica?
The standard procedure is usually a partial hemolaminectomy, removing a small piece of bone, plus discectomy, removing the herniated fragment pressing on the nerve.
What about minimally invasive techniques?
They've gained popularity. However, the sources mention some evidence suggesting that certain minimally invasive approaches might actually be less effective, potentially associated with more residual pain or higher rehospitalization rates compared to standard open techniques in some studies. Needs careful consideration.
When would fusion be done for sciatica?
Fusion is generally only considered if there's significant associated instability, like a degenerative spondylolisthesis, along with the disc herniation. It's not typically part of a standard discectomy for sciatica.
Okay, that covers lumbar radiculopathy well. Let's transition up the spine now to pain in the neck and shoulder. How do these principles apply there? Are things similar?
Many principles are quite similar, yes. Pain often originates from the cervical spine structures or surrounding soft tissues. It's often aggravated by neck movements associated with tenderness, limited motion.
Is it harder to figure out where neck-shoulder pain is coming from?
It can be tricky, yeah. It's important to differentiate true cervical spine pain from problems originating in the shoulder joint itself, or the brachial plexus, the network of nerves going to the arm, or individual peripheral nerves in the arm.
How do doctors sort that out?
History and exam are key. The sources provide a helpful table comparing typical pain patterns and neurological findings for cervical nerve roots versus specific peripheral nerve problems in the arm. EMG and nerve conduction studies can be very useful here to localize the problem precisely.
Trauma is a major concern in the neck, right? Because the spinal cord is right there.
Absolutely. Fractures or dislocations in the cervical spine carry a high risk of spinal cord compression, which can be devastating. Immediate immobilization is essential if suspected.
Imaging for neck trauma.
CT is generally the preferred imaging for significant neck trauma. For lesser, low-risk trauma, those same clinical decision rules, and SUS, Canadian C-spine, can help avoid unnecessary x-rays, but again, caution is needed in vulnerable groups like the elderly. Whiplash is also a common neck trauma, likely involving facet joints, as we discussed. Imaging usually only needed if symptoms persist beyond 6 weeks.
Cervical disc disease, is it similar to lumbar disc issues, degeneration, herniation?
Yes, very similar concepts. Degenerative changes in neck discs are extremely common on imaging, often asymptomatic.
Ah.
Herniation, most frequent in the lower cervical levels, C5, C6, C6, C7, can cause pain, tingling, or numbness radiating from the neck into the shoulder, arm, or hand following a specific nerve root pattern, radiculopathy.
Symptoms besides radiating pain.
Neck pain itself, stiffness, limited range of motion are common. There's a test called Sperling's sign, where the doctor gently extends and rotates your neck towards the painful side. If this reproduces the radicular arm symptoms, it's positive, suggesting narrowing of the nerve root opening, foramen. Acute herniations in younger adults can be related to trauma. The sources provide another table summarizing typical nerve root findings, C5, T1, though again, there's variability.
And cervical spondylosis, that's the osteoarthritis of the neck.
Exactly. Causes neck pain that might radiate up to the back of the head, occipital headaches, especially from C2, C4 levels, or down into the shoulders and arms.
And this can compress nerves, too.
Yes. Bony spurs, osteophytes, disc degeneration, or enlarged facet joints or uncovered tebral joints can narrow the spaces, compressing nerve roots as they exit, foraminal stenosis causing radiculopathy, or narrowing the central spinal canal itself, potentially compressing the spinal cord, causing myelopathy.
How common is this?
The sources state that about 75% of cervical radiculopathies are actually due to these degenerative spondylotic changes rather than acute soft disc herniations. Myelopathy, spinal cord compression, can occur alone or together with radiculopathy, myeloradiculopathy.
So neck problems can cause leg symptoms.
Yes, cervical myelopathy can present with leg spasticity, weakness, balance problems, sometimes even before significant arm or neck symptoms. So doctors need to consider the neck, even if the main complaint seems to be in the legs.
Imaging for neck spondylosis, MRI or CT.
MRI is generally the best test for visualizing the soft tissues, the spinal cord, nerve roots, discs. CT is better for seeing bone detail, the foraminal openings, and specific conditions like ossification, hardening of the posterior longitudinal ligament in the spinal canal.
If an MRI shows spinal stenosis in the neck but the person has no symptoms, should they have surgery to prevent problems?
Generally, no. The sources state there's no evidence to support prophylactic surgery for asymptomatic cervical spinal stenosis, unless there's evidence of spinal cord compression or signal change within the cord on the MRI, or if there's dynamic instability, excessive movement shown on flexion-extension X-rays or MRI. Just seeing stenosis isn't usually enough reason for preventative surgery.
What are some other causes of neck pain mentioned in the sources, besides discs and arthritis?
Rheumatoid arthritis can affect the neck, particularly the C1, C2 joint, atlantoaxial subluxation, which can be unstable and endanger the spinal cord. Needs careful screening before surgery requiring intubation. Ankylosing spondylitis. Acute shingles, herpes zoster, can cause severe neck or occipital pain before the rash appears. Metastatic cancer can spread to the neck vertebrae. Infections. Rarely, restricted blood flow in the vertebral artery can cause neck pain, cervical angina, or rheumatologic diseases causing shoulder-hip girdle pain might involve the neck.
Thoracic outlet syndromes, TOS, were mentioned too. What are those?
These are a group of conditions causing pain, numbness, tingling, or weakness in the shoulder, arm, or hand due to compression of nerves or blood vessels in the space between the collarbone and the first rib, the thoracic outlet.
Are there different types?
Yes. True neurogenic TOS is rare, usually caused by compression of the lower brachial plexus, CAT1 roots, by an extracervical rib or fibrous band. Causes specific hand muscle wasting and numbness. X-ray and EMG help confirm. Arterial TOS involves subclavian artery compression, causing arm coolness, pain, maybe clots. Venous TOS involves subclavian vein compression or clot, causing arm swelling and pain.
What's the most common type?
The vast majority, maybe 95% of cases diagnosed as TOS, fall into the category of disputed or symptomatic TOS. This involves chronic arm and shoulder pain of unclear cause, without clear objective neurological or vascular findings. Surgery for this type is highly controversial, outcomes are often poor, and multidisciplinary pain management is usually recommended, though often challenging.
What about problems directly with the brachial plexus or other arm nerves? How is that different from neck problems?
Pain from plexus or peripheral nerve issues often starts a bit further out in the shoulder girdle or upper arm, rather than primarily in the neck itself. Specific patterns can give clues.
Like what?
Cancer infiltrating the plexus often affects the lower trunk first, causing shoulder and arm pain and numbness in the ring little fingers, plus hand weakness. Radiation injury often affects the upper trunk, causing more shoulder outer arm weakness and numbness. A Pancoast tumor, lung apex, can invade the plexus causing pain plus Horner's syndrome.
What's acute brachial neuritis?
That's an inflammatory condition. Typically starts with sudden severe pain around the shoulder blade or shoulder, followed days later by weakness, usually in the muscles around the shoulder and upper arm, upper plexus distribution. Sometimes follows an infection or vaccination, can cause a winged scapula if the long thoracic nerve is involved. Recovery can take months or even years.
So EMG is important here too.
Crucial. EMG and nerve conduction studies are key to distinguishing whether the problem is in the cervical nerve roots, the brachial plexus, or a specific peripheral nerve further down the arm, like the median nerve in carpal tunnel or the ulnar nerve at the elbow.
And shoulder pain itself can be confusing, right? It can feel like neck pain.
Absolutely, especially if there aren't clear radiating nerve signs. Mechanical shoulder problems, tendinitis, bursitis, rotator cuff tears, frozen shoulder are common. Pain is often worse at night, with local tenderness over the shoulder and aggravated by specific shoulder movements like abduction or rotation.
What's a key differentiator?
True shoulder joint pain usually doesn't cause focal neurological signs. No specific muscle weakness, no reflex changes, no sensory loss following a nerve root pattern down the arm. Also, if the examiner can gently move the shoulder through its full passive range of motion without significantly worsening the usual pain, it makes a primary shoulder joint problem less likely to be the sole cause of pain felt near the neck or radiating down the arm.
Okay, so based on the sources, how is neck pain typically treated? Is the approach similar to low back pain?
Generally, yes. The evidence base isn't quite as extensive as for low back pain, but the overall approach and principles are similar. Spontaneous improvement is common for acute neck pain. The goals are usually rapid return to function and symptomatic pain relief.
So for acute neck pain without radiculopathy, what are the first steps?
NSAIDs or acetaminophen for pain relief. Using cold packs or heat initially might feel good. Educating the patient about the likely favorable natural history is important, helps avoid fear and unnecessary tests. Muscle relaxants, like cyclobenzaprine, might help with spasm and sleep if taken at night.
What about exercise or therapy?
For non-traumatic acute neck pain, supervised exercise focusing on gentle neck and shoulder range of motion, like shoulder rolls, neck stretches, plus mobilization seems to be effective, according to the sources.
What about for whiplash?
Evidence is more limited and sometimes conflicting for whiplash treatments. Gentle mobilization combined with exercise may be beneficial. There's insufficient evidence for traction, TENS, ultrasound, trigger point injections, Botox injections, or antidepressants for acute neck pain or whiplash.
Soft collars.
A soft cervical collar can provide modest temporary comfort by limiting painful movements. Low risk, low cost, might be reasonable for short-term use. Massage might also give temporary relief.
And for chronic neck pain, longer than 12 weeks.
Supervised exercise programs appear helpful here too, for both symptom relief and improving function. Acupuncture might offer short-term benefit compared to sham, but again, the sources point to the potential placebo effect.
Spinal manipulation for chronic neck pain.
Spinal manipulation alone has not been shown to be effective for chronic neck pain, and it carries potential risks, particularly in the cervical spine. Exercise seems to be the more evidence-based approach.
Surgery for chronic neck pain without nerve compression.
Similar to the low back, the evidence supporting surgery, like fusion, for chronic neck pain in the absence of radiculopathy or myelopathy is described as weak by the sources.
Okay. What about neck pain with radiculopathy pain shooting down the arm from a pinched nerve?
Similar to sciatica, this often has a favorable natural history, especially if it's from an acute disc herniation. Many people improve substantially on their own over weeks to months.
So initial treatment is conservative.
Yes. Initial management includes NSAIDs or acetaminophen, possibly muscle relaxants. Avoiding activities that trigger the pain, engaging in gentle supervised exercise, and importantly, avoiding prolonged inactivity are recommended.
What about steroids or injections for neck radiculopathy? Are they used?
Short courses of high-dose oral steroids, like a methylprednisolone pack, or epidural steroid injections performed under imaging guidance, can be effective for providing temporary symptom relief for acute or subacute disc-related cervical radicular pain, according to the sources. But they note the studies aren't as rigorous as one might like, and crucially, the risks of injections are higher in the neck compared to the low back. Potential complications include artery dissection, spinal cord injury, or even stroke from injected particulate matter. So benefits need careful weighing against risks.
Opioids.
Collars. Opioids might be used for severe pain short-term, like in the ER, or for a brief outpatient course. A soft collar can sometimes help symptomatically by limiting neck movements that worsen the arm pain.
When is surgery considered for neck radiculopathy?
If the cause is bony compression from spondylosis causing progressive foraminal narrowing, periodic follow-up is reasonable, and surgery can be considered to prevent neurological progression, even if pain isn't the main issue.
And for pain relief?
For pain is the primary indication, surgery can provide more rapid relief than conservative care. However, the sources state that the long-term outcomes after 1 to 2 years, comparing surgery versus non-surgical management for cervical radiculopathy, are unclear. Similar to sciatica, the long-term results might converge.
So when is surgery clearly indicated?
Indications include progressive motor deficit, weakness, functionally limiting pain that has failed an adequate course of conservative management, similar 6 to 8 week time frame, or signs of spinal cord compression, myelopathy.
Okay. And surgical options?
Common options include anterior cervical discectomy, removing the disc from the front, sometimes combined with fusion, ACDF, or posterior approaches like laminectomy or foraminotomy, opening the nerve root exit from the back. The sources mention the issue of adjacent segment disease.
What's that?
After a fusion, the levels above and below the fused segment might experience increased stress and degenerate faster, potentially requiring further surgery down the road. The sources note a risk of about 3% per year, or 26% over a decade, though they question if this is purely a complication of fusion or partly just the natural progression of underlying spondylosis.
Wow. Okay. That was a truly comprehensive unpack of these sources. We've really gone deep into the anatomy, the different ways pain shows up, how doctors investigate it, that vast array of potential causes.
And importantly, what the evidence from these sources actually says about treating both acute and chronic back and neck pain, whether it involves nerve roots or not.
It's a genuinely complex landscape, isn't it? But the sources do provide a lot of clarity, especially on what is and isn't well supported by evidence.
They really do.
So what does all of this mean when we try to wrap it up? We've certainly seen the enormous scale and cost of back and neck pain globally, and just how incredibly common these conditions are in our lives.
And importantly, we've learned that many cases, particularly those acute episodes, have a really good prognosis and tend to improve significantly on their own over time. Natural history is often favorable.
What's really striking to me reading through all this is that consistent theme. How often findings on imaging, like MRIs or CT scans, things like disc bulges, degenerative changes, or arthritis are present in people who don't have any pain at all.
That disconnect is crucial. And how relying solely on a scan without correlating it closely with the clinical picture can potentially lead down paths of unnecessary tests, unproven treatments, interventions that might even carry risk without clear benefit.
It really fundamentally shifts the focus back to the patient, doesn't it? Back to your specific symptoms, how they affect your life, what the physical exam shows.
And towards evidence-based treatments that focus on function, like staying active for acute pain, and structured exercise and psychological therapies like CBT for managing chronic pain effectively.
This raises a really important question, I think, for you, the listener, to consider. Given how incredibly common these degenerative findings are in scans, even in completely pain-free individuals, and the potential for those imaging findings alone to sometimes lead towards interventions that these sources suggest aren't strongly supported by evidence, how can you, as an informed learner navigating your own health journey, best approach your back or neck pain?
Yeah, how can you focus on what the evidence presented in these sources truly champions like activity, exercise, managing psychological factors, rather than perhaps getting sidetracked by incidental findings on a scan that might not even be related to your current symptoms?
Something to think about as you move through your day.